Hi, this is Erin from Educated Nurse, and welcome back to our channel. Today we're going to do a lecture on sepsis. If you're new to our channel, make sure you're following us on Facebook and Instagram, and then pop over to our Etsy shop where we've got a bunch of gifts, t-shirts, stickers, and merch for the healthcare person in your life. All right, so for today, when we look at sepsis, we're going to look at prevalence, just see how serious it is, which it is pretty serious. We're going to look at pathophysiology. We're also going to dive into who might be at risk for sepsis, look at symptoms and clinical presentation, look at some SIRS criteria, which we'll talk about later. And then we'll also look at diagnostics and interventions. So follow along with us as we dive into sepsis today. So to start off, if you don't know me, this is just a little information about me when you can read about it on your own time. I'm also just going to include a disclaimer that all the information that's presented is really just for continuing education and training purposes. If you are working in a hospital or you're working in an EMS agency, you really just need to treat patients in accordance with your medical direction and your EMS and hospital policies, as it certainly could be different than the information that I'm providing you. All right, so to start off, what is sepsis? Sepsis causes extensive physiological and biochemical abnormalities, which leads to organ dysfunction, and this is all in response to an infection. It occurs when your body has this overwhelming and life-threatening reaction to an infection, and in some cases, if this organ damage cannot be treated, it can lead to death. Sepsis in and of itself is a form of distributive shock, and most often it's caused by gram-negative and gram-positive organisms. How prevalent is sepsis? It's pretty prevalent, more so than we think. Each year, 1.7 million people in the US develop sepsis, which is approximately 50 million people worldwide. Sepsis is responsible for approximately 11 million deaths worldwide each year. And it's the number one cause of deaths in hospitals, the number one cause of readmission, and the number one healthcare cost. So it's a big deal, and we need to be better at recognizing signs and symptoms on presentation and then doing a better job at initiating treatment quickly. And we're going to talk about that. All right, let's look at sepsis pathophysiology. Sepsis leads to profound cellular, circulatory, and metabolic abnormalities. Ultimately, it can lead to circulatory collapse with persistent hypotension, despite fluid resuscitation and inadequate tissue perfusion, that ultimately results in tissue hypoxia. So let's take a peek at this sepsopathophysiology kind of cascade. First of all, the microorganism is going to invade the body. And just going back to school and nursing school and EMS school, immune and inflammatory responses are triggered and exaggerated. Those white blood cells, specifically the neutrophils and macrophages, get sent to the site of the infection. Endotoxins from the microorganisms stimulate the release of cytokines, which is going to lead to increased inflammatory response and vessel change and damage. Cells are going to continue to break down. More cytokines are going to get released, and this causes uncontrolled, unregulated infection. Vessel lesions are going to increase the risk of clots due to this infection process. Coagulation is going to increase, platelet activating factor, and then fibrinogen is going to decrease. So again, we're going to have clot formation. Approximately 30% of patients will move into a DIC state due to increased clots and decreased fibrin. Above all, looking at this whole pathophysiology map, this is going to lead to increased oxygen demand with limited supply, decreased cardiac output, and decreased tissue perfusion. All of this, coupled with altered metabolism, is going to lead to profound organ dysfunction. There are 4 stages to sepsis, and we're going to break them down. First, the initial stage. This begins at the cellular level. Cellular metabolism changes from aerobic to anaerobic, which then creates lactic acid, and we're going to talk about why lactic acid is important later. In the initial stage, it's not always clinically apparent in the patient's symptoms. We might not recognize symptoms, and the patient might not recognize abnormalities in their symptoms either. In the compensatory stage, the body activates neural, hormonal, and biochemical mechanisms to overcome that anaerobic metabolism. Early shock will begin. The patient will start to show signs of increased oxygen demand, supply issues, decreased cardiac output, narrowed pulse pressure. The sympathetic nervous system will try and compensate by vasoconstricting vessels and releasing releasing natural vasoconstrictors like epi and norepi. Heart rate will increase, respiratory rate will increase, neuro changes might occur. I always tell my students the first stop on the oxygen train is the brain. So neuro changes might occur due to that decrease in oxygen up to the brain. And blood will begin shunting to the vital organs. So the patient, or you, might notice in their symptoms a decrease in GI and GU function and decreased tissue perfusion. In this stage, the patient, and they might not know it, they probably won't, but they're going to start to have bowel ischemia and acute kidney injury is going to start to set in. In the progressive stage, this is where we need to intervene, or the patient is going to go into MODS, which is going to be something that we might not be able to fix. In the progressive stage, compensatory mechanisms are going to fail. The patient's going to go into septic shock. They're going to have altered mental status. Their cardiac and respiratory systems are going to begin to fail. There's going to be a severe decrease in cardiac output, decreased perfusion. The patient's going to become edematous as vessel walls fail, allowing that shift of fluids. There's going to be sustained hypotension despite your fluid resuscitation, dysrhythmias, myocardial ischemia. They could have a heart attack, respiratory distress, pulmonary hypertension. They could go into ARDS, and then we've already talked about DIC and acute kidney injury. In the refractory stage, recovery is pretty unlikely at this point. They're going to have massive decreased perfusion from vasoconstriction, and decreased cardiac output is going to worsen anaerobic metabolism, which is going to increase that lactic acid buildup, which is then going to lead to capillary permeability and dilation, and everything is going to start to leak. Symptoms in this stage, you're going to have that profound hypotension, again, despite doing fluid resuscitation, massive edema, respiratory collapse, altered mental status. Your GI-GU systems are going to fail due to a lack of blood flow, and the patient is not going to be able to compensate, and likely your interventions are not going to help. Next up, let's take a peek at who's at risk for sepsis. So really, patients with any sort of recent or ongoing infection, our number one contributors are pneumonia, UTI, peritonitis. Other patients that are at risk for developing sepsis are patients with indwelling catheters or central lines. So this could be a midline, a PICC line, a port, etc. Other populations are your young and old, patients with comorbidities, diabetes, heart failure, COPD, your malnourished patients, patients who are immunocompromised. Okay, so think about those populations. Other patients that could be at risk, we talked about comorbidities, so patients with diabetes, cancer patients, patients who have chronic kidney and liver disease, those immunocompromised patients like our transplant patients or our oncology patients, patients who are using steroids for autoimmune, patients who have just had major surgery, trauma, and again, we talked about those indwelling catheters. You can think about dialysis patients too. And then again, your extremes of your age, you're young and you're old. Many patients can be at risk for sepsis. These are just some risk factors, but always keep it in the back of your mind that your sick patient could certainly develop this while they're with you and in your care. All right, let's look at some sepsis complications. The first one is septic shock. We're going to talk about septic shock and what that looks like. Patients can also develop systemic inflammatory response syndrome, or SIRS. And when we look at diagnostics and triaging of these patients, we're going to look at SIRS criteria to help us differentiate if the patient could be potentially having sepsis. And then we briefly touched on multiple organ dysfunction syndrome, or MODS. Just a little tip, when the patient transitions over to septic shock, 60% of patients will die once they develop circulatory or cellular or metabolic abnormalities. So we talked earlier about how it's super important to intervene in those early stages so the patient doesn't progress. Because certainly, and we're going to look at a little bit of statistics here later, it doesn't take long for these patients to really get in the weeds in terms of developing symptoms and starting to have some organs failing before they really get into organ dysfunction. All right, this is super important, and one of the probably the most important things you can do is recognize that the patient has sepsis. And we have some things that will help us called SIRS criteria. These SIRS criteria, in order for a patient to be septic, you need 2 or more of these SIRS criteria to be positive or present. But we're going to talk about how the clinical presentation might not always be accurate. And first and foremost, if you are an EMT or a paramedic, or these patients are coming to you in urgent care or the emergency room and you're triaging them, this is a quick and easy way for you to think about, gosh, could this patient be septic? All right, and it's just by obtaining their vital signs. So let's talk about these. The first SIRS criteria when we're looking at pulse is a patient who's tachycardic at 90 beats per minute or higher. When you're looking at blood pressure, the systolic is going to be below 100 and the MAP is going to be below 70. And this is not just one value, right? Because I always tell my students and new nurses that I'm training, one value means nothing, right? This is sustained hypotension. So more than one value, more than one blood pressure reading. When you're looking at respiratory rate, they're tachypneic at greater than 22 respirations per minute. Hypothermia or hyperthermia, so greater than 100.9 or less than 97 degrees Fahrenheit. And I will just tell you from my own personal experience, some of the worst septic patients that I have ever seen are the ones that are hypothermic, to the point where I was like grabbing a second thermometer because I did not believe how hypothermic they were. But that makes sense, right? Because their body's kind of normal regulation and compensatory mechanisms are failing, and so they're not able to increase their temperature and create that fever to fight off infection. So those compensatory mechanisms are failing, and they're becoming hypothermic because their body can't raise their body temperature to fight infection. And like I said, the 2 patients that I've seen were about 90 degrees Fahrenheit, and I absolutely could not believe my eyes. And it took multiple thermometers to kind of confirm this low body temperature. So keep that in mind when you start to see your patient getting hypothermic. Oxygen, it's going to be less than 92% on room air in a patient without known lung disease. So like your COPDers, right? They're always going to be a little bit lower. So keep that in mind. Hyperglycemia is going to be greater than 140 in the non-eating, non-diabetic patient. And we're going to talk about how blood sugar elevations are a little bit okay to kind of feed that fever, but we don't want to be too high. And then white count, low or high. So again, you need 2 of these things to be positive to have a positive SIRS criteria. And these are really basic skills, right? Getting vital signs is a basic skill. Now I want to just say this with a caveat. Be mindful of the clinical presentation. Right? So we can think of some disease states or clinical presentations where you're going to have these alterations, but it just doesn't make sense, right? So I'm thinking like a patient who's having an anxiety attack, right? They're going to be tachypneic, they're going to be tachycardic, but they're not necessarily going to be septic. A patient who's in pain, maybe they were just in a car accident and they have trauma and they're in pain. Well, their blood pressure and pulse might be elevated. They might also be tachypneic. But that doesn't mean that they're going to be septic. So make sure that their clinical presentation fits with the sepsis criteria. So just remind yourself of who might be at risk for sepsis and does it fit with the sepsis criteria. So once you bring the patient back or you're looking at more assessment criteria, other things that you're going to see with sepsis, obviously decreased cardiac output, you'll see those changes in vital signs. You might start to notice neuro changes. Again, the first stop on the oxygen train is the brain. So if the brain's not getting enough oxygen, they could be agitated, they could be altered, not answering questions appropriately, confused. So just think about that. Once they start to get hypoxic, you'll notice those neuro changes. When you do your respiratory assessment, they'll have abnormal lung sounds potentially, hypoxia, hypoxemia, respiratory failure, ARDS, pulmonary hypertension. When you look at their skin, they could be warm and flush, or they could be cooled and mottled. And again, that's a late sign. Probably more so when that blood starts to shunt to the vital organs. That's when you're going to see that cool mottled appearance. And again, they're going to be more hypothermic. And then GIGU, we kind of talked about this. You'll start to have patients in acute kidney injury, so decreased urine output, GI bleeding potentially, and paralytic ileus in the bowels because everything is going to start to slow down. So I just want to throw this in there. It's super important. Sepsis is all about time. The risk of death from sepsis increases by as much as 8% for every hour that treatment is delayed. Gosh, that is just so significant. So please, please, please recognize those SIRS criteria and intervene as soon as possible. We don't ever want to let the patient go into septic shock and MODS because we know that it can ultimately lead to a negative patient outcome. So recognize those SIRS criteria and act immediately. All right, let's look at some sepsis diagnostics. Again, use those SIRS criteria. They're not diagnostic, but it can certainly lead you down the right path. When you look at labs, CBC or a complete blood count is where we should start, right? Increased or decreased on the white blood cells. We're going to look at that platelet level when we talked a little bit earlier about clotting, right? So look at those platelets and then certainly look at your red blood cells and your hematocrit. If the patient is dehydrated, you might see that hematocrit be elevated. Get a CMP or a BMP, again, looking for that elevated glucose, and the CMP and the BMP are going to be your metabolic panels, comprehensive or basic. I personally love a comprehensive. It's got that kidney function and liver function on there, where the basic only has a little bit of kidney function. I think it's really important, especially when you're thinking about liver function and filtering and, how is the liver excreting things and metabolizing things. I think it's important. I like a comp, but it's up to the doc. A lactate, this is your gold standard. Make sure you absolutely get this lab. A lactate. It's a green tube. It should go on ice. Get your lactic. Anything greater than 2 is suspicious of sepsis, but absolutely anything greater than 4 is something that, red flags, ding, ding, ding. We need to check this out. Because lactic can be elevated in other disease states. It can be elevated with certain medications. But again, looking at that clinical picture, looking at your base deficit, usually you're going to see that on a VBG or an ABG. You'll get that base deficit, so you know how much you have to correct to make them less acidotic. ABGs, are they acidotic or alkalotic? You can get a VBG, but ABG is really the gold standard. It's going to look a little bit better at that oxygenation component. Blood and urine cultures. So if you think that your patient is septic, absolutely, let's get a blood culture. Let's get some urine. If the patient has a central line, like a port or a midline, get one set of cultures off of that. That's always, one of those risk factors for sepsis. Get your inflammatory markers. So your CRP, you might want to consider a procalcitonin if the patient is having respiratory symptoms and you think maybe a pneumonia is happening. So get your inflammatory markers. They're probably going to be increased. And then looking at that urine again, get a UAUC. You might want to look at, is the specific gravity increase? That might tell you a little bit about that urine. Other diagnostics, if you think that, the patient is having a pneumonia, get a chest x-ray. You might need to consider a CT scan if you think there's something in the chest or bowel related. But really, the lactate here is the gold standard for sepsis diagnosis. And then, investigating, getting some of these other labs will help you kind of pinpoint and narrow down where that infection is occurring. So once you diagnose your patient, then you need to focus on treatment and initiate these cares right away. So the Society of Critical Care Medicine just last year in 2023 has put out the recommendation that within 1 hour, you're doing all these things. It used to be that you get your labs within 30 minutes, you start your fluids within 1 hour, and antibiotics were within 3 hours. And they're really saying, nope, we need to do all these things within 1 hour. So we need to recognize the patient is septic. We need to measure that lactic acid level. We need to get our blood cultures before we start antibiotics, right? We need to administer broad spectrum antibiotics. We need to start start fluids. And then if the patient is still not getting their blood pressure up based upon fluid resuscitation, then you're going to start a vasopressor. And they're saying all of these things need to be done within 1 hour to really help the patient have the best chance at survival. We're going to break these down a little bit farther. When I started working in the ER as an ER nurse, we all had to be on committees, and I was really passionate about sepsis. Many people don't know that I was a cancer patient. I had breast cancer, and I've been 7 years cancer-free. But when I was going through my cancer treatment, there was a concern for sepsis, and it was healthcare initiated. And so I really got passionate about sepsis. And so when I was working at the university hospital, I was really passionate about raising awareness on sepsis, figuring out what patients are really at risk, and then expediting our assessment and interventions. So what we did is we created a code sepsis, and really the goal of the code sepsis was to bring resources to the bedside to help us rapidly assess the patient and start treatment. So, and really, like the adrenaline junkie in me, I mean, who doesn't love a code, right? You hear it overhead and you're like, yes, a code. Well, just have that same excitement when you're treating a septic patient. But really, the goal was that we're going to initiate this code sepsis based on the vital signs and those SIRS criteria and get extra resources so we can get that line and labs going. We can get fluids going. We can get antibiotics going. So first, the goal was to really identify that the patient was septic. So triaging them in a timely manner or getting those vital signs in a timely manner, recognizing those SIRS criteria, and then again, correlating that with the clinical picture doesn't make sense. Really, the nurse or the doctor should see the patient within 10 minutes, and if you have standing orders, initiating those standing orders, and then call overhead that code sepsis. Get those resources to the patient to get those things expedited. Second, you want to start resuscitation efforts. So support those ABCs. Get the patient on some oxygen if they're below 90%. Support their oxygen if they're hypoxic. Consider intubation. Consider a central line. And then what other lines do you need? Do you need an NG or an OG or a urinary catheter or something? Making sure that you're getting 2 IVs. I always say 1 IV is good, 2 is better. When we talk a little bit about treatment, you really should have 2 because you're going to be administering multiple antibiotics, potentially electrolyte replacement, multiple bags of fluids. You might have to start vasopressors. So really 2 large bore IVs is super important. Get those labs. Remember the lactate and the blood culture. Get that within 30 minutes. And then get your other labs, your CBC, your CMP, your liver panel, your coags, potentially a D-dimer. Get those repeat ABGs going. And again, consider a central line, especially if you think you're going to need to do vasopressors. Get that fluid resuscitation going. Normal saline or lactated ringers is recommended. It used to just be that we would throw 2 or 3 liters at everybody. The Society of Critical Care Medicine recommends 30 milliliters per kilogram, and that's your actual body weight, not your ideal. And this just helps support tissue perfusion. Most will get between 1 and 3 liters, but obviously be very careful with like your patients that have other comorbidities that might not be able to tolerate large amounts of fluid. And then be careful with lactated ringers because of that conversion to lactate by the failing liver. So if you have a liver patient, you might want to just be extra careful with lactated ringers. And again, you want to get those fluids started within 30 to 60 minutes. MAP is the primary indicator of perfusion. However, we want to watch urinary output and neurostatus also. If the hemoglobin is below 7, maybe consider a blood transfusion. Again, kind of correlate that with the clinical picture, figure out what's going on. After your fluids, if the patient is still hypotensive after fluid resuscitation, a vasopressor should be added. Something like norepi, which is Levophed, epi, or dopamine. And actually, Levophed is the go-to vasopressor in sepsis. But you know, it's just like the old adage, right? Levophed leaves them dead. So Levophed is going to work on contractility too, and help with cardiac output. And the only way that that works is if the patient is adequately fluid resuscitated, because a pump can't squeeze if there's nothing in the pump. So you got to making sure that there's fluids on board too. And the goal when you're looking at blood pressure and fluid resuscitation and potentially needing a vasopressor, the goal of the MAP is greater than 65. Then you want to get those antibiotics started ASAP. And again, it used to be that you start them within 3 hours. Now the recommendation is within that 1 to 2 hour time frame. Earlier the better. Most patients are going to get like a combination of Zosyn and vancomycin. Again, we talked a little bit about that gram-negative, gram-positive bacteria, but most sepsis is caused by E. coli, staph, strep, Klebsiella, MRSA. So Vanco and Zosyn are the go-tos. You could also consider ceftriaxone, cefepime, meropenem, and then antifungals if your source is a fungus instead of a bacteria. Other things to consider: nutritional therapy due to that hypermetabolic state. Glucose levels should be less than 180. We like a little bit of blood sugar elevation. Again, we want to feed the fever. We want to feed the infection a little bit so our body continues to work, right? Our cells need sugar and oxygen to work. But we certainly don't want it out of control, so keeping that blood sugar tight and less than 180 is good. Consider stress ulcer prophylaxis, like a PPI, like a omeprazole or something like that, Protonix, just because the stress of the situation in that hypermetabolic state could certainly cause some stress ulcers. Due to them being in a hypercoagulable state, we want to consider DVT prophylaxis, so heparin or Lovenox. And then kind of a questionable therapy, literature is not really sure how it works, but considering steroids just to help reduce that inflammatory process that's going on. Again, it's questionable, not a lot of evidence on it. And then lastly, considering disposition, depending on where you work, can this patient be managed where you are? Do they need to go to a higher level of care? Is the patient getting better or worse with your treatment? Do you need to make adjustments? And then thinking about, does the patient need to go to the ICU? Do they have some surgical need that you need to consider? Just thinking about disposition a little bit and what's best for the patient and where they need to go to get the best care possible. All right, so the teacher and me, we're going to do some practice questions just to kind of review the information. And I'll let you have some time just to kind of think about these as we go, and then certainly pause if you need to. But question number 1, sepsis causes system-wide vasodilation, which leads to an increase in systemic vascular resistance. In addition, septic shock causes increased capillary permeability and clot formation in the microcirculation throughout the body. True or false? All right, that answer is true. Question number 2, sepsis is considered what type of shock? That answer is distributive. Number 3, you're caring for 4 patients. Which one is most likely to develop sepsis? A 35-year-old with renal insufficiency has a Foley catheter and a central line in place? Ooh. A 55-year-old male with recent kidney transplant? Ooh, they are immunocompromised. 28-year-old female with diabetes who is in DKA? They're already acidotic, so maybe. 65-year-old male recovering from a STEMI? Probably not. Which one is most likely to develop sepsis? What do you think? So A is the correct answer, right? So they have comorbidity of renal insufficiency, kidney insufficiency. They have a Foley catheter and a central line. So Foley catheter and a central line, that's 2 lines that potentially could give us an infection. And they have kidney disease. Ooh, that's a trifecta. That's bad. Question number 4, name 2 SIRS criteria. All right, so you could list any of them. It could be pulse, respirations, temperature, blood pressure, white blood cell count, any of those SIRS criteria, they would fit in here for question number 4. Question number 5, one of my favorite questions. 1 IV is good, blank is better. That's right. 1 IV is good, 2 is better. Just because you're going to have to give a lot of different fluids and meds and everything, you really should have 2, especially if you're going to run a vasopressor. A vasopressor should run by itself, and antibiotics, depending on where you work, it might be the protocol that you run them independently. So 1 IV is good, 2 is better. Name 3 labs that you would draw if you suspect your patient has sepsis. Possible answers here: CBC, metabolic panel, cultures. Get that lactate. Lactate is your gold standard. Get your coags, a D-dimer, a CRP, procalcitonin, a urine, etc. So many lab choices, but that lactate is the gold standard. Question number 7. A patient in septic shock receives 2 liters of normal saline IV fluids. However, this was unsuccessful in maintaining tissue perfusion. As the nurse, you would anticipate the physician to order what next? A, 2 more liters of normal saline. B, a unit of packed red blood cells. C, a colloid like albumin. Or D, a norepi infusion. The answer is D, a norepi. So if you have a patient that is still hypotensive despite fluid resuscitation, the next thing we're going to do is add a vasopressor, and we're going to titrate that based on MAP. Question number 8, a septic patient is experiencing hyperglycemia. What is the glucose goal for this patient? The answer is D. We want to keep that glucose less than 180. Question number 9. I should wait for blood culture results to start antibiotics. True or false? The answer is false. We want to get those blood cultures drawn right away with our labs, and then we're going to start antibiotics. The cultures have to be drawn before antibiotics are given. However, we do not need the results before we start antibiotics. That's why we do that broad spectrum antibiotic. And then once we get the cultures and sensitivities back, we can adjust the antibiotics, but you have to draw them. You do not need to wait for the results. Question number 10. As your patient recovers, name 2 measurements that can be monitored to assess organ perfusion. Think about the brain, the kidneys, cardiac, etc. All right, some examples could be neuroassessments, repeating ABCs and vital signs, and assessing urine output. All right, so the last thing here, just a sepsis review. Sepsis is a medical emergency. It's really important that we identify that the patient is septic, thinking about that clinical picture and recognizing those SIRS criteria. Initiate that code sepsis. Really make it important that you get resources to the patient. Support ABCs, start an IV, 1 is good, 2 is better, draw those labs. If the lactate is elevated, start fluid resuscitation. If the patient is hypotensive after fluids, add a pressor. Don't wait for those cultures to return to start antibiotics. Get them going right away. Manage your ongoing symptoms and really think about that definitive level of care for that patient. Thanks for following along on our sepsis lecture. This is my list of references. If you have any questions, don't hesitate to reach out. And certainly follow us on TikTok and Facebook and Instagram. Check back often on our YouTube channel. There's going to be new videos on various topics coming every week. So follow us and check back often. Thanks again for following along today. I hope you learned something. Have a great day.